New Education. We are looking at another case study here. This one I'm going to call a language disconnection. Language disconnection. This patient is Cambodian. I don't speak the language that she speaks, and it was very, very difficult to explain to her what a 4-unit bridge is actually doing. And when she has a failing posterior abutment, which is number 2, what are we planning to do, or what can we do when this goes down? She has a big infection and abscess right in here, and root canal treatments and things like that really won't afford her really much time, even if they are successful. There's just not any bone really to support that bridge long term. She has other issues here with the furcation involvement, a very weak lateral here. She's got a tooth that's broken off here. And getting the language barrier kind of covered, I found that Google Translate actually can help out quite a bit. I did this with a Portuguese speaking patient, and her case was not even possible. She had no bone, and she was very confused because she didn't have a translator. But Google Translate actually did a very good job at getting my precise points across. Now, there are certain things that it can't translate. It's kind of funny because you'll find that there are things that they're not translatable, at least from a point of view of a AI type of service, or like this Google service or something like this, translation, without a human taking the nuances of language and how to manipulate it in the translation to make it say what you want it to say. But I found with the particular patient, I didn't use it directly with this patient much as I did with this Portuguese patient, and it really, really helped quite a bit. So in lieu of that, that could help you very much so. This is a starter case, so let's look at the treatment assessment. That is mostly green. The bone is green. The density is green, the ridge height is green, the sinus is green, the detached gingiva is a light green, but no big deal, and the constriction is a yellow. It's only because you have a little bit of constriction showing off here. And let's look at the CT and lead in with that. We have this area here that we like to put an implant in. And the problem I had with the discussion was, what do I do with this? We are going to redo the crown here, so she has a little bit of decay here, but I've got this perio problem coming from the lingual wall. So we're going to scale that and try to keep this tooth, knowing that this tooth is possibly going to need to be extracted. So one of my difficulties was trying to explain to this patient that she could do an implant here and here at number 5 and number 3 and do a 3-unit bridge, or we could do an implant here at number 4 and number 3, try to save this tooth and let that go, knowing that it's a little bit weaker because of the length of the root, but this perio problem here, and I know we'll take care of the decay. And hopefully we don't have a root canal situation going on, so that would not be good. So eventually she elected to just go with implant here and here. And I hope that she understood. I had her take pictures. I explained to her the primary chewing area concept between here and here. And she kept coming back talking about, can she just redo the bridge? But I kept trying to explain that this tooth has to come out. This is not, she's very tender to biting, it's abscessing, so this needed to come out, not be saved, but it was a very difficult thing to try to get that concept that you can't just redo this and put it back on the same foundation, you know. And so That was the hurdle, and it took me a few tries to get it through, but we finally settled on a financial arrangement to do the implant here, and clean this. And so we'll be doing more of a cleaning generally for her, and we have a crown here and possibly an extraction there. So let's look at this implant site. This is what it looks like. I give it a green because this is pretty ideal. You have a bit of a constriction, but the size of the implant still fits really well. You've got a, let's see if this is it. Yeah, so this is a 4.2 by 11 and a half. Fits really nicely in there. The density of the bone is perfect. You really got a great setup here. She's got this nice facial bone coming out here. You can even angle it a little bit like this and get that in really nicely just to kind of match the occlusal compression load that you're going to be putting on it. The only thing I have about this patient is she's got this amount of bone on the outside, which tells me that that was probably building more like tori around the tooth before she lost it. And when I look at the palate, she's got very large tori here, and that tori tells me that there's a lot of stress in the posterior. Whether or not she's still doing that is another question. So she does have some strong bone going on throughout, which is nice, and she maintains a high quality of bone, and she's got this giant tori in the palate. So, you know, I think we're still okay there because we have good size implants for the size teeth that we're going to do. And then if we're looking at the implant, we would do something over here. Let me see if I have that implant there. And that's a 5.0 by 11 and a half there. So the bone density becomes a little less, but still nonetheless is pretty ideal, given her situation. And once again, the concept of now we will not be bringing this bite back here, and that it will be much like her bite that she has over here. So she will be more symmetrical. And that idea, that concept that was discussed is a little vague to her. I probably spent about an hour just on this concept alone, and spent very little time explaining about how weak this one is and how this is kind of weak and this is weak too. So she's okay. I got the point across about that she may need another implant here in the next year or two, and that's not something I normally would do. I would be more likely favorable to keeping the tooth if I can, but thinking that I'm going to keep it for 5+ years. And I think we actually can if the perio problem goes away in the next 6 to 7 or 12 months, somewhere in that time frame, to make sure we keep this at bay. Then I think for sure we can keep that 10+ years, so long as we don't end up with root canal type stuff. But so I'm guarded and hopeful at the same time, I guess. Discussed a little bit about furcation involvements here and here. This one's probably going to be needing something probably sooner than this one. It's hard to say. This one's already involved through here, and it's not looking much better than that. And so we have a sinus that's way up here, and if this becomes lost sooner than later, then that might be good because we can maintain the ridge height here and then have a successful implant placement there. So this is a great starter case for somebody that does it, and hopefully you can use Google Translate. Hopefully that's a tip that could help you out. But this is just a simple, straightforward case study. I like some simple ones, and people can search for our subscription for other simple idea ones that you use a CT, that you know how to do this and guide it. If you want to do this guided, that's a great one as well. This is a good guided case as well if you want to learn about using surgical guides, because you have a tooth-borne situation here and you have 2 implants on the right side if you're a right-handed dentist, that you will get those in very nicely without any kind of really real difficulty when you're doing this. So a flapless one would work here too with guided surgery. So anyway, we hope you enjoyed this case study. Like us on Facebook and subscribe to us on YouTube. and look for our live broadcasts that we do from time to time, and just check out the other videos. Great. Thanks, I appreciate it.